Hello, good evening, and welcome to the CPD Meet webinar on this lovely Wednesday night. My name is Andrew Ormerod, and I'll be the facilitator for tonight's webinar. And so tonight's webinar is presented by Andy Thomas, and Andy Thomas is going to tell you and walk you through managing traumatic cardiac arrests. And so without further ado, I should hand you over to Andy, and hopefully you'll be able to see Andy's screen. Are you there, Andy?
Yes, I am, Andy. Thank you very much. I'll just bring the presentation up now. Hello. Good evening, everybody. My name's Andy Thomas, and I have a couple of jobs, actually, so I'll quickly introduce myself before we start. I currently work as a clinical and education specialist for Medtree, which is a UK distribution and manufacturing company. I also work as a senior paramedic on the critical care ambulance response unit within the North East Ambulance Service. I have a couple of additional roles that are non-paid in terms of I chair the paramedic advisory group for the Faculty of Pre-Hospital Care. I sit on the Trauma Care Council as the paramedic representative, and I do a few other bits and bobs, but I'll not bore you to death. Tonight I'm going to be talking about traumatic cardiac arrest, a time for change in paramedic and pre-hospital care practice. And until recently, I was a paramedic in the military, predominantly working on the MERT in the deployed operations. And this is when traumatic cardiac arrest really became a passion of mine, and I gained a greater understanding from the extensive numbers of patients we've seen in traumatic cardiac arrest in Afghanistan on board the helicopter on MERT. And it's from those experiences and looking at the literature and looking at basically a mindset that I'm going to talk to you about this evening. As always, my Twitter handle is at the bottom of the screen there, Andy Thomas 135, and if you want to ask any questions after the webinar or want to make any comments on the presentation, feel free to tweet me on that. I will endeavour to respond, obviously not whilst I'm speaking. I'm a man, so I can't multitask, but I will endeavour to respond afterwards. If you want to use a hashtag for this evening, I just put this in last minute. Obviously, CPD Me are kindly hosting us this evening, so thank you to Andy Ormerod. And if you do your hashtag CPD Me TCA, that should collect any comments from anybody who wants to make it again this evening. And again, there's my Twitter handle. So I think the first thing to say before we move on into the presentation is, as Yoda once said, you must unlearn what you've already learned, I think, when it comes to traumatic cardiac arrest, and you've certainly got to open your mind. Because what we're going to talk about today is nothing particularly different, nothing particularly exciting. It's just a change in thinking and a change in how we go about our business. Now, I'm not sure who's paramedics, doctors, nurses who are listening in this evening, but I predominantly aim this talk at the pre-hospital care practitioner, and I aim at those who are working outside of critical response teams, because they may be doing similar things, but those who are often first on scene, those who are managing a part of who don't get exposed that often, but also those who are working in critical care and other places will find some value in this presentation. The first thing to talk about is historic dogma. Now, traumatic cardiac arrest is often, basically in history, been thought of as an area that is futile and is not particularly worth making any efforts with the patient. Not so long ago, although 10, 12 years ago now, the people listed on the screen, the National Association of Emergency Medicine and the American College of Surgeons came up with some guidance and went to withhold resuscitation in trauma because they felt outcomes were poor. So injuries incompatible with life, I think, is fair enough. Evidence of rigor mortis, again, I think that's quite reasonable. We'd all agree. And then this is when it starts getting controversial slightly. So trauma with no ECG activity at the scene. So your asystolic patients, it was deemed futile to make any attempts. If the arrest was witnessed and you'd had 15 minutes of unsuccessful CPR, the traumatic patient arrests in front of you. After 15 minutes, you just give up the ghost. And if it's a little bit far to hospital, then we wouldn't bother neither. And it's this kind of publication, I think, that ingrained the dogma that was out there that, these patients will not survive. Prior to what I'll talk about the game changers in a second, is prior to this, traumatic cardiac arrest in various studies, which I've taken out for the purposes of tonight's presentation, so I don't bog you down too much, is predominantly surrounded around survival rates between 0 and 2.3 to 2.7% on some studies. And that's not great, really, when you think about it. Although, if you compare that to some of our medical outcomes at the moment with an ambulance service in the UK that's under great stress and pressure, you could argue some rates are getting worse than that. on the medical side. However, a few things happened with traumatic cardiac arrests. A publication in 2006 by Dr. Davis and his team down at London HEMS in a case series of around about 909 patients showed a 7.5% survival to hospital discharge rate from out of hospital cardiac arrest, which was really a game changer at the time, I think. And then from experiences within the military in Afghanistan, they started seeing around about an 8% survival from traumatic cardiac arrest, and we're going to explore a little bit why that is, and also look at how we can try and support that system. And because obviously it looks very nice there on the pictures with a couple of helicopters. However, not every patient's going to get attended to by a helicopter. Often first on scene is going to be basics responders, road crews, possibly even CFRs, first aiders, and you know, everyone has a place to play in the survival rate. So quickly looking at the London HEMS review, as I say, which I think was really a game changer, and fair dues to London HEMS, they're often at the forefront of these things. So it was a 10-year retrospective analysis. It was survival at hospital discharge, which is, I think, key target to look at. It's whether the patient gets home. 909 patients included in the study, which is a good sample size and really gives validity to the study. And as I said, 7.5% survival rate with 68 surviving to hospital discharge. It was a defining review, and it proved that from traumatic cardiac arrest, with the right expert team, more can and obviously should survive. It did note, however, within the study that cardiac arrest as a result of hypervolemia is almost always fatal. And therefore, what they were looking at predominantly in the study is patients who had stab wounds, and often these traumatic cardiac arrest patients receive resuscitative thoracotomies either pre-hospital or in the hospital phase, and that's quite key sometimes to survival at what stage that may or may not happen. By people able to do things like resuscitative thoracotomies, as you can see here, these sort of patients can survive these traumatic cardiac arrests by either repairing injuries to the heart, clamping in the aorta with your fist, as you see the HEMS paramedic or doctor doing in the screenshot here, and really give people something more to think about when it comes to these patients. But as I said, then these teams are not always first on scene, and we've got to get them to this stage or support them to this stage. The military study was slightly different, although, and I can say anecdotally from my experience, I think the survival rates were probably across the entire conflict, and to be fair, probably increased as the conflict went on. However, we looked at a small period, 8-month period, or my colleagues did in the military, and this was a prospective observational study. So prospective is often better than retrospective studies, because you're looking for an outcome at the start. However, there's obviously limitations to this study. It's only over an 8-month period. Only 52 patients met the inclusion criteria at the time, and ROSC was achieved in 27% of these patients. 8% of them, which is only a small number, number 4, survived to hospital discharge fully neurologically intact, with 3 of those patients have been their primary cause of the arrest was exsanguination, so hypervolemia. And it's that group that the military found, and certainly from my personal experience out in Afghanistan, most of our patients were hypervolemic traumatic cardiac arrests as a result of IEDs, and we set up a system to really combat that. And again, we must stress with the military population, it was predominantly, although local civilians were involved, it was predominantly a young, fit, fighting force who were therefore giving themselves every chance of survival due to their status at the time of injury. A couple of other things that this study found: 1 patient survived after 24 minutes of resuscitation. So again, that patient group from the historic dogma, after 15 minutes we wouldn't have bothered. Interesting, within this study, all survivors arrested during the helicopter retrieval process. So in this period, they arrested on board the aircraft, which obviously has a high-end capability, and this may impact the resultant survivors. Although I'll give you case examples of others that don't arrest in flight. And no survivors in this case presented with asystole. So asystole still had a poor outcome in this military cohort. And again, anecdotally speaking, we found we could often get ROSC certainly on patients from hypervolemia when they were getting to the agonal rhythm, but obviously often very difficult once they progressed to asystole. But again, I'll come on to a case example where asystole can survive. And again, looking at these images, I'm not flashing these up to deliberately show any gore, but if you look at the extent of the injuries here, the patient on the left is obviously a double amputee. One leg's been stripped back, the others torn and got partially compressible. Tourniquets are applied, and these patients again benefited from fantastic care by medics on the ground in the battlefield, from combat medics from the Army and Navy and Air Force, and they would provide great care to the patients early doors. They could put tourniquets on themselves, their buddies would be straight on them with tourniquets, and I think this hugely supports and helps with survival. The patient on the right is an interesting patient that I've flashed up to show you. This is in the emergency room at this stage, so the patient's getting to a hospital level of care, and as you can see, despite the tourniquets being applied, you can see one being tightened in the screen there's still a lot of bleeding happening and a lot of fresh blood coming out of this patient, and often they were very difficult to control just with tourniquets because the artery would retract and the patients would continue to bleed, often not in a catastrophic manner, but certainly a flow or an ooze, and this provided unique challenges in that environment as well to get these patients to survive, but they can, and they did. So I've showed you there some examples from effectively what London HEMS early progressed and what the military model, which incorporated, I think, the fine work that London HEMS had done before them, and probably took that to the next level. Existing paramedic practice is traditionally based around ALS and JR-CALP, and most people who work in the pre-hospital care environment outside of sort of the HEMS or critical merit environments work to similar protocols, and they say now that it would be, let's initiate a bit of ALS and include a bit of airway management, a bit of CPR, give some fluids, and rapidly transport the patient to the hospital regardless of the mechanism of trauma. So let's scoop and run, hope for the best, and do what we do for medical arrests. Now that is changing with the new Resus Council guidelines, and I'll come on to that towards the end of the presentation. But I'll leave this slide in there as a reminder, because I've been presenting this for about 18 months at various conferences now, and I think it's always to remember the origins of where that came from. So in simple terms, I asked you to open your mind. Now we must change that mindset. We must change that JR-CALP, that ALS guidance, that, well, we do this for arrest patients if we really want to maximise the outcome of traumatic cardiac arrest. 2009 I put on there, and that was a change in managing a traumatic cardiac arrest, and again this was a change in military practice over in Afghanistan. Prior to that point, we would follow ALS guidelines, we would on the arrest patients, and that's how we would deal with them. And then we started looking at this and saying, well, this is not really working for this subgroup of patients, these patients with these horrific injuries that we see on the battlefield. What can we do differently? And I wasn't involved in this at all. However, a lot of the clever people in the military at the time got together and started coming up with what we call clinical standard operating procedures, specifically around traumatic cardiac arrest, to see what we could do differently and to improve this. And this coincided with January of 2009 that we started carrying packed red cells on the aircraft and fresh frozen plasma, so some components of blood. And when I refer to blood products, I'm talking about packed red cells and FFP. Often people use the term blood, but blood has lots of other factors in that are taken out once they're broken down, so we have to be careful of our terminology there. And basically the standard operating procedure that we endorsed, it prioritised itself into 4 basic categories. Control the hemorrhage and restore the circulating volume. Again, very military focused on this environment, I appreciate that. Sort an airway out properly, and ventilate the patient appropriate. It wants you to limit the tidal volume because obviously we want to reduce the intrathoracic pressure, so we get that venous return via the inferior vena cava back to where we need it so blood comes around. If appropriate and needed, get an early decompression of the tension pneumothorax, and where indicated and appropriate, carry out a resuscitative thoracotomy. Now, when we talk about the civilian environment, it's the civilian environment we see lots of resuscitative thoracotomy to help cardiac arrest survivals in the pre-hospital phase. That's because of blunt stab wounds. In hemorrhage, that was often not done in the military environment, and we did very few of these on board the aircraft, for example. It wasn't commonplace, and I think that's something to bear in mind. We further broke it down into, in effect, what we felt were some reversible causes. So catastrophic hemorrhage or processes and protocols were to prevent further blood loss. This was often done prior to the arrival of any sort of helicopter advanced care. This was really done by the guys on the ground and done really well. We very much focused on apply or retighten them as well. Often in transit they'd move, so that was one of the first things we do. And apply appropriate hemostatic and pressure dressings. We were using cell oxes or hemorrhage hemostat of choice at the time. Obviously, there's many more products out there now, and I'm certainly not promoting one or the other, so please don't think I am. Hypoxia was get a definitive airway as soon as possible, and this was in 2 stages really. So the guys on the ground would have an OPA, an MPA, and if that didn't work, they didn't carry eye gels, they didn't have LMAs, and they certainly they didn't spend any time messing around trying to intubate. They were trained and given empowerment to perform surgical airways where indicated. And I've done some other research on surgical airways with my colleagues at the Department of Academic Emergency Medicine, where we retrospectively analysed all surgical airways done on the ground, and they were getting 92% success rates on that, and we're starting to speak on that and just getting a publication together, which will be out shortly. So it's another interesting area. On board the aircraft, that was often done either with intubation without drugs in the traumatic arrest situation, or if the patient was peri-arrest, that might have been done via an RSI. And again, commence appropriate ventilation. Decompress the chest, again, we put on here with bilateral thoracostomies. If that was on the aircraft, that would be, as long as positive pressure ventilation was on there, that would be our standard protocol. If there was multiple patients and we didn't have positive pressure ventilations on the ones that had the tensions, then we would use the appropriate needle decompression at the time. Hypervolemia, again, get IV and IO access very rapidly. I think the IO is another thing that was born out of conflict. Gone are the days where we carried the cup needles and just for use in kids. We were struggling gaining access on these patients and started using a lot of IOs to gain access, and therefore I think for civilian practice I would always say in traumatic cardiac arrests or in trauma in general or in any arrests, when you're getting into your situation and your bandwidth's slightly tighter and you're just getting into the situation, then consider IO early. And you can always place a secondary IV line once you've got a bit of stability or you've got a bit more bandwidth available to you. And at the time, we were given red cells and FFP, so packed red cells and fresh frozen plasma at a rate of 1:1, and we were carrying 4 units of each on the aircraft. The tamponade was something we saw very rarely, and again, we talk about resuscitative or clamshell thoracotomy, but as I say, that was rarely needed. Often this would take place more in the emergency department, and certainly I've seen a fair few lung twists being performed very quickly after we arrived at hospital from gunshot wounds to the chest. For spinal cord injuries, if that resulted in a traumatic cardiac arrest, we would follow the ALS guidelines. And hyper and hypothermia, because in the winter it was freezing out there, and if you get them on, try and keep them warm. And in the summer, we could really see heat illnesses causing. And to the extent we had arrests from heat illness, that obviously needed cooling rapidly. So it gave us a bit of structure and something to pin our shirt on, for want of a better word. I'm going to talk through a couple of quick case examples now. There's 2 military ones and then a civilian case example. The first one is a military example. So this patient was a gunshot wound to the left thigh. He was in a FOB location, so for those not in the military, that is kind of like a base out in the desert or out in the green zone or wherever. So semi-safe. It's not out there on the ground necessarily right at the coal face of fighting. And when the crew were flying out to this patient who'd been removed from the point of injury back to the base, on the way there they got told that the patient had gone into traumatic cardiac arrest 10 minutes before they'd arrive on the scene, and that the guys on the ground there had started CPR in a controlled hemorrhage. So the crew landed on, and just as they were landing on, they could see CPR ongoing as they came into land. The patient's always prepped, ready for the helicopter coming in close to the HLS. The patient came on the aircraft, and the first thing that was stopped was CPR, or external chest compressions, and the doctor, the lead physician at the time, is the person in that situation, would confirm traumatic cardiac arrest. It was at the same time, it was a very pit stop approach, as is used in the civilian terms. We used to refer to it as a zonal resuscitation, and the nurse's responsibility in that situation would be get pads on early whilst the paramedics were doing hemorrhage control and getting access immediately. It was kind of like everyone do it at the same time. And it was noticed that the agonal PEA rhythm with a distended abdomen, and if you remember me talking about it before, it was often that agonal PEA rhythm that we knew if we got them at that stage before they went asystolic, that we had a chance. So the patient was intubated without drugs and had an initial end-tidal CO2 reading of 1.2, received 4 units of packed red cells and 4 units of FFP in flight, was given TXA and calcium chloride, and ROSC was achieved in flight to the extent that the patient began to bite down on the tube and required sedation and paralysis for further safe transfer. What you'll notice on there is no CPR was performed. I've not put it in there because There was no CPR performed on this patient during the flight. It was felt hypervolemia was his cause. Therefore, let's focus on the reverse and that cause, and everyone's effort was focused on stopping the bleeding and increasing the volume, and that was something we started to do in Afghanistan. 5 days later, this patient was discharged. He was an Afghan military person, and he was discharged to an Afghan hospital, fully neurologically intact. And I'll show you now his CT scan. As you can see on the right-hand side, that's his CT scan, and if you look down there at his external iliac artery, just coming through there, you'll see his right one's fully intact, and his left one, it's severed that, pinged around in the pelvis, and hence why he had quite a distended abdomen. He received surgery, and by the surgery he had some form of ligation performed, and as I say, he returned, it was fully neurologically intact. And again, he'd been down 10 minutes before the arrival of the aircraft, so it proves these patients really have a good chance of survival. That was a full doctor-led one patient aboard the aircraft team. I'm going to talk about a paramedic-led resuscitation now. This is one I was personally involved in. We were called to 2 patients at this time at a grid location. There'd been a RPG attack with some small arms fire follow-up, and there was 2 patients. When we landed at this hostile location, of the paramedics' job, so my job was to get off and get the patients onto the aircraft. Unfortunately, the way we'd landed, the teams that were bringing them on were coming towards the front of the aircraft, and we were on a slight incline, so to be honest, they were potentially going to walk into the rotor blade. So my initial thing was to make sure they didn't do that, get them round. So I didn't get a particularly good handover as we were running towards the aircraft. And I actually swapped the load round of the patient, so the people on the ground were always told to load the sickest first, which in this case they had done. I mocked one eyeballed both patients, and I actually felt the other one looked sicker. So I swapped the load round, and we split down when we had 2 patients, 3 patients, 4 patients, etc. So it was a doctor nurse looking after patient number 1, which went on first, and it was myself and the other paramedic looking at this patient we're going to talk about. So it had been from a rocket-propelled grenade attack. So if you watch the movies, a bazooka type attack. It's not a very military term for it, but yeah, rocket-propelled grenade. So they cause explosions. The guy was a 16-year-old male at best. Now that's how old they have to be to join the Afghan security forces. But if I'm being honest, he was probably younger. He had a left arm amputation, and on examination, he had a really boggy and deformed pelvis, which had been wrapped up in endless amounts of dressings by the ground call sign. And we arrived on scene 29 minutes after this patient had received these injuries. He was on arrival. He was in traumatic cardiac arrest, and we don't know how long he'd been in traumatic cardiac arrest. And he'd had limited treatment on the ground because they were still in a firefighting hostile situation. So we confirmed the traumatic cardiac arrest when he came on. We made no attempt to do external chest compressions at this stage, and again he had the classic agonal PEA. He was intubated without drugs using an air track device, which was something we would use at the time just to make it easier on the aircraft, and he had a FAST and a humeral head IO inserted. He received 2 units of packed red cells and 1 unit of FFP by the paramedics and given TXA. As I said, no external chest compressions were performed and no ALS drugs given again, and that was standard as per the previous case that we weren't given ALS drugs, so adrenaline, in want of a better word. He showed signs of improvement on the aircraft. We got him back into what we called a PEA arrest, and his heart rate was starting to come down, but we couldn't feel any pulses still at the time. We handed him over to the ED team to continue the resuscitation, and they obviously have really rapid infusions, so they start hitting him with quite a lot of blood products, and they quite quickly regained a ROSC on this patient. Sadly, with this patient, on primary X-ray, he had really unsurvivable injuries. His pelvis, unfortunately, I haven't got the image to show you, but was literally shattered where the RPG had hit him, and this young chap wouldn't have been able to survive. So treatment was humanely withdrew, and the patient passed peacefully. But it's just the idea that we can get these patients back, and until we get them to a hospital, know exactly their injuries, and then make a decision whether to continue or give up. We don't often have that information in the pre-hospital care environment, and therefore this is almost an example of we've got to try and we've got to get them there so we know what to do. And again, that's just an indication of the type of injury that patient would have been suffering from. So the final case is a ambulance service in the UK HEMS joint mission. It was a male in his early 20s, motorbike versus car, 60 plus miles an hour, and the car had an external bullseye on the screen. and it looked from what the HEMS doctor I spoke to at the time really passed this case on to me, that the patient had effectively taken most of the impact. The rapid response vehicle paramedic was conducting a BVM ventilation, and the bystander, a police officer, was doing external chest compressions. Excuse me. The doctor remembered he noticed quite a deformed right femur when he approached initial assessment. CPR was stopped and not stooped, as per my typo on the screen there, and the traumatic cardiac arrest was confirmed by the HEMS team. The patient was asystolic and was intubated without drugs. A pelvic binder was applied, and bilateral thoracostomies were performed. The patient had 300 to 400 mils of blood removed from both sides. The chest is indicated obviously bilateral hemothoraces, and he was gained. The paramedic who was already on scene then gained IV access, whilst the HEMS paramedic gained IO access. And the patient received about 1,800 mils of saline. This at the time, this is a couple of years old now, weren't carrying blood and was given TXA. So on the base of it, he's asystolic. This is not really worth. This is the kind of job we're talking about where previous guidance said let's not even make the effort. But the team quite rightly made an effort with this patient, and we're going to give a bit more details now. So overall, he had 2 litres of crystalloid because no blood was available. This was slightly different. The doctor continued chest compressions around interventions, but didn't let the chest compressions interrupt interventions. And again, at this stage, it wasn't widespread practice to stop chest compressions and just concentrate on the reversible causes. So he managed that, but he did not let them get in the way of patient care. The patient had fixed and unreactive pupils, but no external sign of a head injury. After the 1,800 mils mark, the physician who was attending this patient just describes, just suddenly on the screen, he saw a single complex, a single PQRS complex, and thought, that's odd, and continued on. He gave a further 200 mils, continued chest compressions, and then plus 11 minutes after they arrived on the scene, he basically describes as this patient just kicking in on a normal sinus rhythm, and had a strong carotid pulse and achieved ROSC. In flight, the obs were 80/40 blood pressure, end tidal CO2 was 2.8, and obviously the TXA was actually given in flight. They pre-alerted the major trauma centre and requested obviously cardiothoracics as well due to what they got out of the chest. The patient lost the femoral pulse in flight and was given a further 200 mils of saline, remember, so we'll come on to that in a second, but this is all they had, saline, yet they're getting a result from it as well, and I think that's important to remember. On arrival at the emergency department, patient's heart rate was 130, BP 80/40, stats were great, and his end tidal CO2 was reasonable considering the trauma he'd undergone. What was the outcome of this? And the patient did re-arrest at the MTC. He had a clamshell thoracotomy performed. He had a T4-T5 fracture dislocation, and he had a ripped esophagus vein, which was probably some of the problems that we were finding in the chest. That was clamped. He was given further blood, and he had received damage control surgery. 4 hours after that, stable, as stable as a patient can be following those injuries. The pan-CT showed no injuries apart from the chest and the femur. However, 8 hours post-injury, the patient did start to show signs of raised intracranial pressure, and unfortunately this patient's CT showed that he had a massive diffuse axonal injury, and sadly died 48 hours later. But the point again here is he was asystolic, he got to hospital, potentially without this head injury, which nobody could have predicted at the time. This patient would have otherwise survived the traumatic cardiac arrest. But more importantly, he was an organ donor, and as due to those actions, other people will have received this patient's organs, and often we don't think in that sense when we're looking at trauma patients when we're doing this, but this is a classic example. We don't know what the outcome is going to be until we get them to the level 1 trauma centres potentially, and therefore by getting them to the trauma centres, they may not only survive, but if they don't sadly survive, then there's other things that may benefit the greater good. So what are the take-home points so far in the presentation? Now I'm approximately sort of 25 minutes into it, is that these patients can survive, and our role in the pre-hospital environment is to sustain some kind of life or support the treatment, start the treatment, so the hospital teams and the surgeons and etc. have a chance to put right the damage that's caused and give these patients a chance. I'm going to talk around external chest compressions, a little bit about airway and ventilation, and a little bit about adrenaline. So, chest compressions. Now, I mentioned our practice in the military is we'd stopped generally doing chest compressions and traumatic cardiac arrests. which I have to say when we first changed it was quite a mindset change. And again, we'd all trained to say in hypervolemia, in the tension patient, in the patient in tamponade, it's not going to do any good. Yeah, I have to say the first few times those decisions were made, generally people did chest compressions until we got used to it. So it's not an easy thing to change. What I would say with external chest compressions is it does get in the way when you're trying to do your reversible causes. So the traumatic cardiac arrest is often not truly an arrest in the true sense. It's often low flow state, which is basically reduced volume and a low CO2 production. If you were to ultrasound all these patients, then some of them would have a beating heart, although no matter how hard you try, you wouldn't feel an external palpable pulse. The thing with chest compressions, if the heart is empty, if it's under pressure from a tension, or it's clogged up with blood from a tamponade, jumping up and down on the chest is probably not going to help them, because if there's no blood, you're not pushing anything around. The tension's going to prevent the blood going around, and the tamponade won't allow the heart to contract properly. So you need to address those reversible causes, and chest compressions should never get in the way of you addressing those reversible causes. It won't improve them. However, if you're in an environment, and I appreciate with ambulance services and around the country, you've got to work with protocols and procedures, and as long as it doesn't get in the way, then you're not doing any harm with chest compressions. But say, for example, you're a paramedic who needed to do a decompression, then I would suggest, if that's the cause of the traumatic cardiac arrest, then you concentrate on getting that decompression right and making sure it works, as opposed to trying to do things whilst you're doing CPR. Airway and ventilation. Now, I could talk about people overventilating, and if there's a 70-kilogram male, you should have 420 mils or 560 mils of air between your BVM. Bear in mind, a BVM contains about 15 to 1600 mils of air, so you want to squeeze about a third of that in there. But generally, people struggle to remember that. And when I present this face-to-face at conferences, I tell a little anecdote how to remember this. And I wasn't going to bother tonight, but I'll give it a go. It might come across a bit odd on the on a webinar. I have to say I've not done this on a webinar, so not seeing people's reactions. Basically, imagine myself. So I've met a girl, and I've decided, to take her out, and we've went out on our second date. Actually, second date's probably a bit inappropriate. Say it's 7 or 8 dates down the line, because I wouldn't do this after a second date, obviously. And the evening goes well, and she invites me back for coffee. So we go back for coffee, and things are moving progressively nicely on as we like, and it gets down to the nitty-gritty. So bear with me, guys. This has got a point. So we start, having a little bit of a fondle, for want of a better word, and it comes to taking the bra off. Obviously, like most men, I probably have a little bit of too much of a fumble there, but I eventually get the bra off. What I'm probably not going to do at this stage is, and forgive me for the pun, but you will remember this and hopefully improve your care and practice when you're ventilating patients, is I'm not going to suddenly start grabbing this patient's hooters, am I, and giving them really hard squeezes every 2 seconds, squeezing the life out of them, because I'm going to get a slap round the face, my coffee thrown on me, and I'm going to get sent on my merry way. What I'm actually going to do is I'm going to gently get my hand, and I'm probably just going to gently stroke over a second or so I think I said the patient's breast, the lady's breast, and I'm just going to tweak the nipples at the end of it with my finger and my thumb, just to make that enjoyable. Then I'm going to leave it. I'm going to let that just linger in the air for 3, 4, maybe 5 seconds, and then I'm going to repeat that process. And if we remember that, guys, if we're always and ladies out there, obviously listening to the webinar, is if we remember that, you're probably not going to overventilate your patients, okay? If you remember this story, the idiot on the webinar, then I guarantee you will probably remember that. That's it. If you bag somebody like that, you probably won't too far off bagging them appropriately. The last thing to remember on this, now I've obviously hung myself out to dry in an inappropriate thing on the interweb, is end-tidal CO2. If you start seeing an increase in end-tidal CO2 in a traumatic cardiac arrest patient, it's a good indicator that the patient's improving. It's the first thing you'll see before you ever feel a pulse, okay? If your end tidal's declining, that's a sign that the arrest is not going very well. We talked about the chest again, and finger or needle with a chest. Now, obviously, I declared at the start I do work for Medtree, which produced the thoraquick on the right-hand side there. We use various needles, standard needles that we use for cannulation, or we do finger thoracostomies. Now, I'm not going to promote, well, I am actually going to promote finger thoracostomies or using a proper device. Cannulas are no good, guys. The stuff you use, the 14-gauge cannulas, I'm sure you've all heard stories, or some of you have used them and they've worked. In Afghanistan, the guys on the ground were using these, and some of them would get through the chest wall. 50% 4.5 centimeter cannulas won't penetrate 50% of the population. And when you insert them, they kink, they clog up, they've got a real narrow diameter, and therefore the patient retentions quite rapidly. And I'd often see patients come on who've suffered from tension pneumothorax with 3, 4, and I even once saw 5 in a single patient where they've had to keep reinserting them. If the patient has positive pressure ventilation, so i.e. you've got a tube down there and you've got a definitive airway, then and you're trained to do so, a finger thoracostomy is the gold standard. However, not everyone's trained. Certainly in the pre-hospital environment, not everyone's trained. So therefore, you're going to have to use some kind of needle to decompress the device. If you're going to use a needle to decompress it, then use something like the ThoraQuick, and just to prove that I'm not just selling that, there's other products available. So Prometheus do the Pneumafix. These are products that are designed specifically for tension pneumothorax and will last a lot longer. For example, it has an 8-gauge cannula, eyelets, etc. Air can only come out of the device, not go into it, and certainly this device on the screen will inflate due to the 8-gauge cannula catheter will inflate the chest from a tension within about 15 seconds. I haven't put the video on tonight to show, but just to give you an idea. So if you're going to do the decompressions, finger thoracostomy, absolutely. If trained to do so, positive pressure ventilation, gold standard. Otherwise, use a proper device, not a needle. That's not going to work. Adrenaline. Now, I'm certainly involved in the Paramedic 2 trial at the moment, as probably some of you are on the line tonight, where we're really trying to prove in the UK practice, in out-of-hospital cardiac arrest, medical cardiac arrest, is adrenaline worth it or not. The evidence so far suggests that you will get an increased ROSC rate from giving a patient adrenaline, but that has no difference in survival or hospital discharge. Obviously, its alpha-adrenal effects cause systemic vasoconstriction, which is why we gave it to improve CPR. But if you think if that's going to clamp everything down, then it's going to increase coronary and cerebral vasoconstriction as well, which is what we don't want to happen. Add down at the top, in trauma, the patient's probably had a massive catecholamine release, so it's dumped all its catecholamines out there, and the vessels are going to be pretty tight anyway. Any benefits that you may get ambulances are now carrying blood, and when I say blood, actually they're carrying packed red cells. They're not carrying blood. Blood has many other things in it. They have logistical issues within the UK on carrying fresh frozen plasma, and some of them will start carrying lyoplasma, which is dried plasma, but it takes about 10 minutes to draw off. It's very frothy and it can be quite difficult. So I've given you some case examples where blood was used and with really good outcomes, but I've also given you a case example where saline was used, and although the outcome wasn't great, the patient did get to hospital. Now, the problem with giving sodium chloride, it will make the patient more acidotic. So in theory, and some of the early evidence may suggest that blood, it will be benefited. Certainly from the military evidence it does. However, that was a very specific cohort of patients who were predominantly suffering from hypervolemia, and 60, 70-year-old people with other comorbidities and things. And so we don't fully understand the true effect of blood yet. And I'm not going to say, I've put this picture up, so if you give saline, you're probably helping Satan open the gates to hell, and if you're giving blood, you're probably helping the good Lord himself close the gates to heaven. I don't think it's as clear cut as that, and there's going to be some UK trials taking place soon, and I'm sure we'll all anticipate those results with bated breath and excitement to see what actually makes a difference. The simple answer, guys, if you've got a patient in traumatic cardiac arrest and they need fluid, you don't withhold saline, you give what you've got. But make sure, if you can get it, that you can get the expert teams, whether it be HEMS, Merit, or whoever it may be, to bring that blood to the scene or get the patient to where the blood is. And I think I won't labour the point anymore on that. So 2015, almost over, and what's this year held for us? Well, it's held the new European Research Council guidelines, which has resulted in the UK Research Council guidelines. And at last, I noticed when I read them, I was quite excited to see they'd actually put a little bit of a trauma algorithm in there. And actually, they started asking us to think a little bit differently about traumatic cardiac arrest. And that's the algorithm as a whole on screen now. And it's quite nice. It gives us something to work to. It doesn't go as far as I would like it to in some areas, but I think it empowers practitioners, paramedics, nurses, physicians alike to make some more decisions. And I'm just going to talk through it in chunk sizes now. So if it's a trauma patient or the peri-arrest, move down the algorithm. If they're in cardiac arrest, the first thing it says is start CPR. And you know my thoughts on external chest compressions in certain situations, but if in doubt, then of course it's not going to do any harm. So you're certainly not going to do any harm with CPR unless they've got really odd chest injuries. And then find out whether it's a likely medical cause, because often what came first, the chicken or the egg? Did the patient have a cardiac arrest at the wheel of the truck before he ploughed through the central reservation? And it's often very difficult to figure that out in our environment. So we've got to probe and ask ourselves these early questions. But if in doubt, then it's suggesting, well, it's not suggesting, it's telling you to start CPR. It talks about then penetrating trauma to the chest or epigastrum, and then if there's any penetrating trauma, consider an immediate thoracotomy, and that's pretty much standard practice and across the country in high-end critical teams. However, if you're a solo paramedic, a St. John crew, a private ambulance company, a nurse stopping by the side of the road, or a basics doctor without that capability, then it's clearly not going to be there for you. You need to start sustaining life and making sure that help's on its way. Obviously, if it's a medical cause, and then follow the ALS algorithm. And then it talks about the treatment of reversible causes. If you look off to the right-hand side there, always continue in CPR. And if it's hypervolemia, if it's a tension or a tamponade, I really wouldn't let CPR get in the way of doing what you need to do. In the other cases, then yeah, crack on, but make sure you keep trying to address those reversible causes. So hypervolemia, pretty much what we said. Control the external bleeding, splint the pelvis and fractures, and get IV or IO and give fluid or blood. It gives you the options to depend on your capability. What I'd like to stress at this stage, which I haven't done so already, is a pelvic binder, and especially in the blunt force trauma we're exposed to more in the civilian environment, is a pelvic binder is a catastrophic hemorrhage control device and should be applied as part of your big C processes in these patients, and it's not a packaging device, okay? Hypoxia, basic or advanced airway management as appropriate. Again, depending on your level, but what I would say for those who are not regularly intubating, and for paramedics, I know we have to log things these days, but if you're not regularly intubating, then please consider an iGel and get an airway. Or if you've got particularly traumatic facial injuries, then I think evidence would suggest now with the correct training, and maybe as advanced paramedics, specialist paramedics possibly should be, have the ability to perform surgical airways. Obviously, give oxygen seems quite reasonable. Decompressed tension pneumothorax, thoracostomy if you can do it, or to the appropriate standard, and in a tamponade, consider the resuscitative thoracotomy. For the, guys, if you've got a patient with hypervolemia and you're waiting for HEMS, or you're waiting for an ambulance back up in the MTC's 5 minutes away, start the fluids, get the airway sorted out, do all the basics really well, and you're sustaining that patient then, so hopefully giving them a chance, because we've seen from some of the examples, 24 minutes of CPR survived, asystole survived. It can be possible, and it can be, and I'm sure we will see more survivors, and those percentages increase when we all start believing in it. Again, pre-hospitally, immediate to the appropriate hospital, in hospital, transfer to the appropriate location. If you don't get a return of spontaneous recirculation, it says consider termination of the resuscitation. But I'd have a lower threshold for termination at this stage, because we know patients can survive. Some things direct from the guidelines: attention, decompress as soon as it's recognised. Focused chest ultrasound can be used to supplement clinical signs to diagnose it. So ultrasound's often used now. It's certainly something we use in our area. Hypervolemia, if profound hypervolemia, it actually says in there chest compressions are likely to be of minimal effect due to poor cardiac filling, etc. I'm not going to read it all out here. So we know if the heart's empty, it's jumping up and down is not going to work. So although it's in the algorithm to do CPR, within the lower text, it gives you empowerment to think about that a little bit more and to make sure it doesn't get in the way. How can this be applied for paramedic or pre-hospital application? I've got about 5 minutes left, so I'll need to get motoring here. First thing, guys, down to skin. There's no point treating traumatic cardiac arrest unless you're going to get that patient naked, and that goes for all serious trauma patients as well. Pre-hospitally in the UK, I think outside of major HEMS units and stuff, we're a bit reluctant to take people's clothes off. And despite my example of how to bag somebody before, I think it's appropriate. You've got to get these patients out of skin and get a true sense of their injuries. control all external hemorrhage and apply a pelvic binder. External hemorrhage we can control. We need to close the box. We need to apply the pelvic binder to try and close the box, because there's no point filling it up until we've controlled the hemorrhage in the first place. Airway, secure as appropriate trained level, so supraglottic airways, eye gels, intubation, and consider a surgical airway if you can't get any of those, or they've got particularly difficult facial injuries. Ensure adequate ventilation, don't overdo it. I think I've laboured the point on there already. And chest seals as required. Now, the new or the draft trauma guidelines from NICE suggest, just put a simple occlusive dressing on there. And I have to say, my gut feeling is I don't agree with that. It's up to yourselves what you think. I just find and from early days of treating patients on the battlefield, that's when sometimes other forces, soldiers were coming on, they put simple occlusive dressings, and I'll be totally honest, they'd always fall off. With a bit of sweat or blood, they don't stick very well. And they're saying, you might necessarily need the seals, but if you can let some air out without letting air in, I don't think that's going to do any harm. So I personally think seals, proper devices, again, still have a place. What device you choose to use is entirely up to you, but you want something that's really sticky. At one point, we used to use Nightingale dressings, and they didn't have a vent on them. We just seal it, and then we create our own holes and release air that way. So yeah, it's up to you to consider that more appropriately. And decompress to the appropriate level, guys. So finger down the needle. Gain the IVIO access. Commence aggressive fluid resuscitation. If you've only got saline, start on that and request blood if somebody's available to give that. Always give TXA, okay, even in traumatic cardiac arrest, get it in there. And remember, external chest compressions can get in the way of you saving that patient's life. However, once you've addressed those causes and you've started filling the patient up, don't be, I'm not saying don't do it. I'm just saying don't let it get in the way of addressing them reversible causes. So another way of looking at this is I spoke on this at quite a few conferences, and then I think it was at the Trauma Care Conference last year I added this into my presentation where I talk about the TCA survival triangle. I'm just going to flick them. First of all, we must sustain life. We might have to give them a slice, and perhaps they will survive. And what I mean by that is the pre-hospital practitioner, paramedic, basics doctor, whoever it may be, nurse, do what we can to our appropriate levels within all the guidance I've talked about, and try and sustain that patient as best you can. That might still be in cardiac arrest. However, that might be a slow flow state. Get them, if you can do it, or the experts can do it, so they're going to need potentially surgical airways, potentially finger thoracostomies, resuscitative thoracotomies, and fundamentally they're going to need the surgeon to get in there and repair the damage. And if we sustain life and get them to that slice, whichever stage they need the slice to whatever injury, then these patients might survive. And I like to think of the TCA triangle there is a little way in our heads to try and remember how they can survive. I think I'd sum this up by to increase survival from out-of-hospital traumatic cardiac arrest, we must believe. Now, 12 months ago, almost to the day, I took my kids onto the Polar Express. They were 5 and 7 at the time, and we got on the Polar Express. It's all green like it's done in the movie. Sorry if you haven't got kids and this is making no sense to you. I do apologise. And we got on this station in the middle of, I can't even remember where it was, but somewhere up in the north here, and we had to drive out in the sticks. And we got on this, and we drove to the, not drove, obviously because we're on a train. We got on the train to the North Pole, and my kids genuinely thought we went to the North Pole. They were that excited because we were on the actual train. Now, in fact, I thought we would probably go to the North Pole at one point. It was that realistic and exciting. And I think we need to take that enthusiasm that kids have, to whether they believe in Santa or believe in the Polar Express or the Tooth Fairy, and we need to believe that our patients in the pre-hospital environment are not no-hopers, that they do have a chance. And actually, although we're probably, yes, going to have to resuscitate 95, 96 patients to get a few of them to survive, if that is your 25-year-old brother, your son, your friend, then and we get 3 or 4 of them surviving out of 100 that we probably wouldn't have tried on before, then potentially that's worth a crack, I think. So that's it from me. Thank you very much for listening. I potentially spoke very fast there, but I was very conscious. I normally do this that was an hour-length presentation that I was trying to squeeze in. So I'm just going to drop my screen size down now. Hopefully, don't cut anybody off, and then I'll take any questions. Andy, are you still there?
I am indeed. Yes.
Yeah.
I think we've just got a couple of questions there, Andy.
Yeah, let me just reduce that screen down, and then if you fire away with the questions, Andy, I'll try and answer them.
I was dreading to see what's going to be on your desktop then when you expose your desktop. Okay, so the first question is, Andy, to what extent has MERIT Afghan changed over our development practice of TCA in the UK?
Well, I think we're getting to a stage. It did make a difference. It was I think Mert made us believe a little bit more, and I think we learned to do the basics right. Now people talk about Mert in Afghanistan, and I worked on that and did multiple deployments on it. But it's actually, as I said in my presentation, it was the guys controlling the hemorrhage first and giving us a chance. They were sustaining life to give them more advanced capability, and then all we were really doing is managing their airway and filling them up. And it was a lot more complicated than that, but in simple terms, yeah, that is. So I think how we try to replicate that in the civilian environment is, quite rightly, our Merit and HEMS guys who work around this country are doing a fantastic job now, and there's been some great work done. The Alton Towers situation was where unfortunately those young people obviously had traumatic amputations and stuff. That was a classic example of how those lessons from the battlefield get applied into the civilian environment. But I think war has always brought things on in terms of trauma. We're not particularly engaged in a ground conflict at the moment, and therefore we're not the guys who I used to work with and don't anymore. We're probably not getting that level of exposure. And I think we're going through a phase now where it's back to the civilians taking the lead and the civilians bringing up the next phases of care, really. So I think it's a lot of things. If anything came out of it, we got rid of the taboo of tourniquets. Because before the conflict, I think everyone thought that tourniquets were devils and horrible things, and we know tourniquets are good. Hemostatics start getting used. IOs came out of the conflict, I think, in a real strong way. So yeah, those three things: so tourniquets and hemorrhage control, IOs, and a belief, really. So I hope that answers your question.
Okay. If anybody wants to ask any questions on your control panel, you should have a box where you can ask questions and we'll read them out and Andy will answer them. Question number 2 was relating to case number 1 on Mert. Just to confirm that the patient was in PEA and that no CPR was performed whilst reversible causes treated. Was CPR then continued to achieve ROSC?
Yeah, I'll confirm that case. Definitely no CPR, no external chest compressions were performed on that patient once that patient came on the aircraft. So they just basically, how it happened, the doctor tubed the patient, the nurse one side and the paramedic the other side got access and started filling the patient up, and the other paramedic would have been looking for external hemorrhage and stuff like that. So no, definitely not. In that case number 1, there was no external chest compressions performed on that patient prior to them getting a ROSC.
Okay, question number 3 for you. Do you think that community first responders will have a bigger input in a traumatic cardiac arrest after arriving first on scene, being able to hopefully improve patient outcomes?
I mean, if you look at the new European Resus Council guidelines, and they talk about progressing catastrophic hemorrhage control management further down the chain, and I'm gonna use the analogy. We use CFRs, and may I just say for the record that I think CFRs do a fantastic job in our community, working as part of the team, making a great difference to out of hospital medical cardiac arrests and early defibrillation. And I'd like to think that's where CFRs can help. So if there's somebody bleeding, I'd like CFRs to have the ability, in which the new guidelines say it needs to be brought down to the first aid CFR level, so they can control hemorrhage, they can be empowered to use a tourniquet, pack a wound with a hemostat if required. And it's not, the soldiers on the ground were trained to do this with minimal training, and I believe that can apply to CFRs as well. So yes, I do see CFRs as making a difference. If you're around the corner and somebody's bleeding, then yes, you're going to make a huge difference to that patient's outcome. What we have to make sure is, if we're going to send CFRs to these things, and this is where the problem will ultimately lie, I think, is with cost and training. You need the appropriate training, and you need the appropriate support, because once we start sending you to traumatic cardiac arrest, it's a greater level of exposure for you, and you just need to make sure you've got the training, you've got the kit, and you've got the support. But in theory, I think we should have hemorrhage control devices side by side with AEDs in the community, with online training videos and other things like that. And I think the first person that muted that to me was a guy called Lee Thompson, who's a trauma paramedic with the North East Ambulance Service, and I heard him say it first, and so I'm kind of pinching his idea here, so I don't want to take any credit for that. But yeah, Lee Thompson came up with that idea that if we can put AEDs in the community at £600-700 a pop, and expect people to grab them off the wall, maybe we should shove a £15 tourniquet in there as well, and maybe some other bandages. But yeah, interesting point. But yeah, definitely a place for CFRs.
Excellent. I think hopefully that answered the question well. Doctors seem to like tranexamic acid stat and paramedics over 10 minutes. Any thoughts?
Oh, thank you. I normally mentioned it in my presentation, but I forgot, so I do apologise. Yes, TXA. Right. Okay. Firstly, if there's any ambulance managers on here and consultant paramedics, then please listen. Unfortunately, for paramedics at the moment, it's on a PGD because it's not on the exemption list, and therefore we have to follow the PGD, which I think says over 10 minutes, and JR Calculator amends it. Yeah, in Afghanistan we gave it instantly, and in my civilian practice now, I would give TXA over a millisecond rather than over faffing around with 10 minutes. I've even seen people talk about getting syringe pumps to give it and stuff like that, and I'm sorry, but traumatic cardiac arrest needs aggressive and positive management. We don't need to get syringe pumps out there. Give TXA. Now, the CRASH 2 trials, which all this data is based on originally, which is a multi-center, multi-nation trial, was, it talks about the effects and the perceived hypertension of giving TXA. Now, people were getting TXA for a reason, because they'd lost a lot of blood, and I think that was probably the cause of hypertension. And therefore, I don't think we need to overly worry about TXA in the trauma patient, especially in the rest. No, give it straight away, guys, is my advice. However, please, obviously, bear in mind with your local policies. I don't want anybody getting in trouble. But I think, in a traumatic cardiac arrest, you're going to be busy enough. You don't need to spend 10 minutes giving TXA when it can go straight in there. And that's in your non-traumatic arrest patients as well, I would suggest. Any other questions, Andy?
So that leads us on quite nicely to the next question, because it said, tranexamic acid in general, can it harm you if it wasn't needed?
Well, I'm no tranexamic acid expert or TXA expert. Anecdotally, and this wasn't related to TXA and other things, we used to give it after 2 units of blood, 2 units of FFP. We'd give the TXA then. Since then, the advice is give it. And if you listen to people like Karim Brohi, Professor Karim Brohi, and others, they say that the chances of giving harm, if in doubt, is limited. There's a theoretical chance you could cause a PE and other things, but if you've got a patient actively bleeding, which through internal bleeding or bleeding that you can physically see, I think it's pretty safe to give the TXA. For some reason, our American colleagues really don't like it at the moment. But the rest of the world do like it. So I think it's pretty safe, and the literature out there is very supportive of that. So my advice is, if in doubt, if you think they're bleeding, then give TXA. It will help.
Okay, on to the next question. Going back to case study number 1, how long was the patient in PEA before you got ROSC?
So he was 10 minutes on the ground. They had a 60-minute flight time, and I think about 10 minutes into the flight, so about 10 minutes, and so 20 minutes post initial arrest. So yeah, 10 minutes after arriving on the MERT, he basically, I think they were about 5 minutes out from the conversation I had with the team to Bastion, and that was a 16-minute flight time, so we're talking 11 minutes. So yeah, probably 21 minutes. But it takes about 90 seconds to 2 minutes when somebody comes on a single patient lift, or it did at the time, for a tube to be down, 2 ports of access, and blood and FFP running. And then obviously one of them they were through IOs as well, so that has slowed the process down through a 3-way tap and 10mm syringe. But we pretty much aim to get the whole 4 and 4 in within 8 minutes with 2 points of access. That would be our aim. So yeah, so I hope that answers the question. So yeah, 11 minutes after flight, but 21 minutes after the actual injury occurred.
Okay, lots of people complimenting Andy, saying thank you very much for the webinar tonight. Last question at the very bottom. Do you have any experience with pediatrics in traumatic cardiac arrest, and has our view changed along with adults?
Sadly, I do have quite a bit of experience with peds in traumatic cardiac arrests, and again, this was from predominantly my Afghan experience, and we'd often have multiple pediatric arrests at the same time, because unfortunately they'd be out playing in the streets, they stand on an IED, and we'd often end up with 4, 5, 6 at once sometimes. So yeah, we followed the same principles. Obviously, their blood volume is so much less, and it takes so little to get them into traumatic cardiac arrest. But again, we'd fill them up. We'd actually bolus them in 50 ml sort of boluses to response. We didn't, sometimes we'd have 2-year-olds, a 3-year-old, a 4-year-old, a 7-year-old, and a 9-year-old on the aircraft, and maybe 2 of them would be in traumatic cardiac arrest. So yeah, that was managed, very delicately. They crash very quickly, and unfortunately, our success rate probably wasn't as high due to the size of them, and they would often have bowel eviscerations as well as their amputations. So, yeah, I think the adult principles can be applied to pediatrics. it's simple, isn't it? If they've got blood on the floor, then we need to try and replace it. If you're going to put them in the civilian setting saline, just manage that till you get a carotid pulse, and then don't overfill them. Is my advice there, because they'll blow off them clots. And but in traumatic cardiac arrest, yeah, it's the same management, aggressive resuscitation. Make sure they're ventilating well, and go from there. Really, as soon as you think you've got kind of an output, or you're not sure, then I think a little bit of CPR wouldn't do any harm. Hope that answers the question.
Wonderful, Andy. Thank you very much indeed. Thank you very much for everybody attending tonight. We've had a good hour's discussion there. Plus, thank you very much to Andy Thomas for presenting that. It was well presented, and certainly as a practicing paramedic myself, some very useful information there. A few people asking, do we get a certificate for tonight? The answer is yes. All those people who have attended tonight, you will get a certificate, and you will also get a digital link to the webinar, so you can use that again for continuing professional development. For those people who are on the list who are active members of CPD-Me, two good things will happen. You'll get the certificate, but it will automatically drop into your CPD-Me profile, which is a brand new technology that has literally just launched this morning. And so all you will need to do is log into your CPD-Me profile. Your evidence will be there, your certificate, your link to watch the video will be there, and also the title of the webinar. You just need to go in and write what you learned from the webinar and how it might change or influence your practice. The webinars are a brand new implementation into CPD-Me, and we have got about 5 or 6 lined up now ready to register. The next webinar we have got listed is on the 12th of January, and that is by Dr. Mike Davis with an introduction to some adult theory learning. And so anybody who's got an interest in teaching or mentoring, that'll be a fantastic webinar for you to register. The next one after that is again presented by Andy Thomas, and Andy's going to be talking about IT clamps and innovative hemorrhagic control, and that is on the 13th. And then on the 22nd, we have got the guy behind the Lewis pelvic applicator, Simon Lewis. And Simon's going to be talking about the novel approach in using pelvic applicators, which was quite topical because tonight, again, we talked about it being used as part of a hemorrhagic control system. And so there is a couple more questions which have just come through, but I am aware that time is coming on. Last two things I want to mention is that as part of CPD-Me, we've also now just teamed up with Trauma Care and launched all their 2015 trauma videos on the website. So anybody who's interested in trauma, there's 140 high-definition videos available within CPD-Me so that you can access them and subscribe to them. I think the cost is £24.99 for a year, but you have 140 conference videos on there with all up-to-date current practice and guidelines, lots of really useful information. And then we've also teamed up with a company called RealDX, who have brought over 600 real-life clinical cases. So these are clinical cases that have been videoed in a patient interrogation, along with differential diagnosis, chest x-rays, blood results, ultrasounds, and lots of other innovative learning material that we have included on there. And so, any questions before we terminate this? We've just a couple more questions, Andy. Are you okay to... In fact,
yeah,
actually,
course,
they're not questions. They are just thank yous. So thank you very much, everybody, indeed, for taking part in the webinar tonight. It's been really useful. And remember, literally just log back onto the website, cpdme.com/webinars or webinar, and you can access all them webinars on there. You do have to be a member to access some of the webinars because some of them are paid resources. But there's one coming up on the 12th of January, one on the 13th of January, and one on the 22nd of January. So that just leaves me to say thank you very much to Andy Thomas for joining us tonight. And thank you very much indeed for everybody spending a good hour with us on this cold Wednesday night.